Hello everyone, I'm Genevieve Yuzunova. I'm a physician psychiatrist and also a researcher. I'm recording this today because it is the intersection of two important observances. One is today 6 Differences in Health Research Day, and it's Mental Health Awareness Week. And it's a day to reflect how far we've come since 1986, when the federal government and NIH established formal policies to include more women and females in clinical research. And before that, the standard patient was the male. And while we have made a lot of progress, we are still uncovering how deep these biological differences run and how they can dictate the success of diagnosis and treatment and development of new treatments. And I'm sure that my colleagues know, but I wish to share some views based on my experience to mark today, to raise awareness, and because I think this may help because it's a very important issue. And as a physician, I have seen the statistics in my clinic. We know that many of the devastating diseases are more common in women, such as Alzheimer's disease, multiple sclerosis, breast cancer, and autoimmune conditions like lupus erythematosus, which is roughly 9-to-1 ratio women to men. And in my field, I see how depression and anxiety are diagnosed in women twice the rate of men. But we have to ask a difficult question. Is this because really men are less depressed, or is it because our diagnostic tools are biased? And what I mean, when I have evaluated patients with depression and anxiety, I often use the MADRS or the Hamilton Anxiety and Depression Scale. And these are the gold standards. However, they focus heavily on the internalizing symptoms of depression, such as sadness or guilt and fatigue, and these are symptoms that are statistically more common to be reported by women. Whereas men often manifest depression differently. Instead of the sadness or the crying that women report, we often see externalizing symptoms such as irritability, unexplained aggression, anger, and risky behaviors like substance use or escapism and spending too much time at work. And so the traditional scales like MADRS can miss this presentation. And this is why it is so vital to integrate other rating tools for depression in men, like the Gotland Male Depression Scale or the Male Depression Risk Scale. MDRS 22. So, if you are a primary care physician watching this, if a male patient presents with a new onset of anger or sudden impulsivity, it is needed to screen for depression. Of course, women may also present with such irritable subtype of depression, but these are symptoms that are more common in men. They may not tell you that they are sad, but their biology is telling a different story. And if we don't look for these differences, we may underdiagnose and undertreat a part of our population, or we may treat them erroneously for other conditions. In men, it is important to know, because we are in Mental Health Week, that they may present, instead of the traditional depression symptoms of sadness and guilt and crying, they may have general physical symptoms such as persistent headaches or digestive issues or back pain, rather than the classical emotional symptoms, because of the brain-body communication. And now to say a few words from the clinic to the lab, because we develop treatments for disorders in the lab. And this brings me to my work as a researcher when I have developed gene therapies for psychiatric disorders and neurodegenerative disorders. We often look for answers in the mouse models, but we often assume, and this has happened to me in my research, that the male mouse brain is the same as the female mouse brain. But we know that there are multiple differences at the level of neuroanatomy, gene expression, behavior, and I will mention just a few. For example, the striatum and the substantia nigra, which are very important in disorders like Parkinson's disease, and also in Alzheimer's disease, in schizophrenia, they are larger in the female mice than in the male. The entorhinal cortex, which is critical for depression and neurodegeneration such as Alzheimer's, is often larger in the female mice than in the male, whereas the hippocampus, which is involved in learning and memory, can be larger often in the male than in the female mice. And this has immediate consequences when we deliver gene therapies. If we are injecting a gene therapy in the exact same stereotaxic coordinates, since they are such small regions, we may not target the exact regions. And this is why I think that we have to calculate for each mouse based on the bregma and the lambda distance to be more precise, and also whenever possible, before conducting the experiments, to inject multiple tracer dyes to see how these regions are located in the mouse strain that we work with, and whenever possible also to do MRI. I know but it is better to perform the experiment slowly but with greater confidence than to hurry and to have results that may not be universally valid. And to say something about the delivery with viral vectors, such as AAV9, it has been found that when these viral vectors are injected systemically, they are taken up more efficiently in the female than in the male mice. And we also know that some behaviors, such as the learning or the Morris-Water maze task, mice perform it more efficiently. So it seems they learn better than the females, which corresponds with their larger hippocampus. Whereas some female mice perform better in the rotarod, balancing behavioral tests, because they are smaller and lighter than the male mice. Of course, this is strain specific. And also a very important point, both in humans and in mice, is that males and females show different responses to stress, and often the females are more sensitive to stress. And so, in closing, I want to highlight the need for precision, which also NIH highlights. And there is a persistent myth that female data is messier because of hormonal cycles. But large-scale meta-analysis show that female mice are no more variable than males based on their hormonal cycles. And so my message is that women are not just smaller than men, and men are not just more aggressive than women. Precision psychiatry and science requires us to acknowledge sex as a biological variable at every level. From the coordinates we use in a stereotaxic frame to the screening scale we use in the clinic and the exam room. And when we respect these differences, we will do better science and provide better patient care. And so, happy sex differences in health research day, and let's work toward a future of truly personalized medicine. What I mean, because we know that our behaviors influence our brain structure, and therefore we also have to have in mind what are the professional and lifestyle factors that could affect disease and health and research and treatment outcomes. Thank you very much for your time and attention. I welcome your comments.